Dr. Mahandesha, am I audible?
Yes, yes, sir. I can. Hello?
Yeah, we can hear you. Do you want to check your PPT once?
Yes, once I'll just check it. Shall I share my screen?
Yes.
You cannot share my screen while other persons share.
You can share now. I've stopped sharing.
Okay.
Yes, we can see you. Not in full, not the full screen, but yes.
Yeah,
We
now
can
it's
see you. Now it's perfect.
yes. Fine, good.
Okay, yes, we can see it.
Yes. Stop sharing.
Yeah, stop sharing.
Okay.
So once I tell you to go, you can start with the
start. I'll do that. Thank you.
We have another 5 to 6 minutes to go. So around 10:30, 10:35, we'll start with the program. Once we hit around 30 to 40 participants.
Yes, I'll do that. No problem.
Thank you.
Okay, thank you.
हाँ बरेजी.
Good morning, all. We'll wait for another 2-3 minutes more. Very good morning, everyone. We'll start with a webinar, the September one. Every month on the fourth Sunday, ISPRP, we have an online webinar. So today we'll start with this month's program. I request Dr. Anita to welcome the gathering. She is the Joint Secretary of ISPRP. Thank you, Anita.
Ladies and gentlemen, respected guests, and dear participants for the day, good morning to all of you. It's my distinct honor and pleasure to welcome you all to today's webinar on soft tissue augmentation in implant dentistry. In this era of heightened aesthetic consciousness and constant global connectivity, our exposure to facial outlook is much more pervasive than ever before. The perception of dental aesthetics has evolved in many ways and it's important that we all know its implications and better understand the finest ways to enhance the same. Today's ISPRP webinar assures to be an enriching experience as we explore on this amazing topic on soft tissue augmentation in implant dentistry. We have brought together a panel of experts and a pioneer who will share their valuable knowledge, thoughts, experience, and expertise with us. Before we dive into this webinar today, I would like to take this moment to share to you that ISPRP is proud in conducting its first ever National Undergraduate Convention on 15th and 16th of this December at SRM Dental College, Ramapuram, Chennai. This convention will be a momentous event to provide a platform for the undergraduate students to enhance their knowledge, exchange ideas, and interact with renowned experts in the field of interdisciplinary dentistry. The convention will feature 3 keynote lectures along with live video demonstrations in the field of 3 specialties. Student events in the form of papers, posters, table clinic presentations, and quiz programs are scheduled. Best presentations will be awarded with honors from the society. It shall be a landmark event, and on the behalf of ISPRP head office and the organizing committee of SRM Dental College, Ramapuram, I urge all of you to be a part of this momentous event and make it a grand success. Without further ado, let us begin this exciting journey of exploration and learning today. Thank you once again for joining with us, and over to you, Dr. Manuel.
Thank you so much, Anita, for the welcome address. Now, it's a pleasure to have 2 people, one a prosthodontist and an endodontist. So I would like to invite both of them, our chairpersons. So first we have Dr. Umesh Pai, who is currently working as an associate professor at Manipal College of Dental Sciences, Mangalore. He finished his PG in prosthodontics in 2006 from KLE Belgaum. He then went on to do training in implantology and maxillofacial prosthodontics from King's College. He's an astute clinician and exceptional academician. He recently visited Tokushima University of Japan to further his interest in learning sleep medicine and sleep apnea. He is the director of Mangalore ITI Study Club, a KOL of Colteen Walden and Privest Denspro. So I welcome Dr. Umesh Pai and our second moderator, Dr. Divya Chowdhury. She completed her MDS in conservative dentistry and endodontics and was the college topper from Korea Postgraduate Institute of Dental Sciences and Hospitals, Lucknow. She is currently a reader in the Department of Conservative Dentistry and Endodontics in ITS Center for Dental Studies and Research, Ghaziabad. Thank you, both of you, for sparing your time, precious time on a Sunday morning. So I request Dr. Divya to introduce the speaker for the day, Dr. Mahantesha.
Thank you so much, sir. A very good morning to one and all. I hereby welcome you all to yet another enlightening ISPRP webinar session being presented by Dr. Mahantesha S. Dr. Mahantesha S is currently an associate professor in the Department of Periodontics at the Faculty of Dental Sciences, Ramaiah University of Applied Sciences. He has finished his master's in periodontics in 2008 from MS Ramaiah Dental College, Bangalore. He has obtained fellowships from International Congress of Oral Implantology, USA. In addition to a rich academic experience, he is a renowned researcher. He has been sanctioned a grant by the Indian Council of Medical Research in 2020 for his projects on implants. He has won numerous awards for his paper presentations and on national and international platforms. He has applied for 2 patents, first due to and and second, analgesic coated surgical sutures. He has also delivered numerous guest lectures and conducted several workshops on lasers and implants. He has well over 30 publications to his credit in national and international journals. As a clinician, he is a resource person for ICOI Implant Fellowship and for ITI Implant course in addition to MaxFace Implant Study Group. He has received training for digital technology in implant dentistry and phonometric concept in implant from Scotland, UK, and Advanced Dental Surgical Protocol Association with the Royal Association of Oral Implantologists, USA, by Dr. Radslaw Zadat. We welcome you, sir.
Thank you so much, Divya. Now I would request Dr. Mahandesha to share his screen. And one request to the participants, please mute yourself. And if any queries are there at the end, we'll address it. Please put it in the chat box. Thank you so much. Mahandesha, I think I'll stop sharing and you can share your screen.
Sure, sir.
Thank you so much.
All right. Yeah. Is it fine, Dr. Manuel?
Yeah, it is fine. It is fine. We can see it. Thank you so much.
Video also? Fine.
Yes, the screen can be seen.
Yes. Good morning, one and all. Thank you very much for giving an opportunity to speak on this big platform. The first and foremost, I should congratulate the team of ISPRP. They're doing a wonderful job, to getting all the three faculties together and discussing their interesting topic and getting know each other and giving a good platform to share their knowledge. It's really a wonderful job, and I'm attending most of the webinars what they're conducting. And before starting my presentation, I would like to thank the president of this ISPRP group, that's Gopi Chandra sir, and the secretary, and he was my guru, he is my guru, that is Dr. Vibha Shetty ma'am. I'm really thankful to her. And I should say thanks to the scientific chairman, the Manuel Thomas, and the joint secretary, that's Anita Kevi madam, then the today's program moderator, Dr. Umesh Pai and Dr. Divan. Thank you all for accepting me, and thank you all give me an opportunity to speak on ISP platform. And this is my favorite topic. Let me start with my presentation. So that's a soft tissue augmentation in implant dentistry. Yes. The most commonly question asked in dental practice, especially in implant dentistry, there are certain common questions, and those questions I enlisted, and I'm going to share those answers for those questions. The first and foremost, why peri-implant mucus are more prone for the inflammation? These are most common questions. That's the reason we always insist for the the maintenance after the implant therapies. This is most important, most critical for the success of any implant dentistry is to maintain the oral hygiene, that is peri-implant health. That's most important. And most of the times we never bothered about the keratinized tissue, but there is a lot of role in implant maintenance, that is a role of keratinized tissue. I'm going to discuss in detail how to augment the keratinized tissue, what is the importance of keratinized tissue, and how to maintain or manage those things. And how to identify, that's most important things, because we are failed to identify the pie type, then we'll end up with the complications, and later we have to think for the maintenance of the complications. Then when is the right time to augment, whether you want to augment the soft tissues before implant placement, or during the implant placement, or after implant placement, or even during the maintenance. This is a most critical period, a critical time to say augment the soft tissues. When you decide when to augment, when you have the idea when to augment the tissues, then outcome is quite good, and there is no problem of the peri-implantitis, and easy to manage and easy to convince the patient. And which graft is the best? That's most important, because nowadays in the market, so many grafts are entering into the market. So each and every company says that this is the best graft to augment the tissues, this is the best graft to get the beautiful keratinized tissue. But we have done quite amount of cases compared to most of the tissue, most of the material which is all in the market. We can share my knowledge. I don't recording that. I'll show some clinical cases. Then every surgery has some complications. I'll share my whatever the problems while during the soft tissue augmentations, the procedure. Let me start with the beautiful cases. The first and foremost, we always remember that we are replacing the last dental organ. This patient comes to us not for implant. The patient comes to us for the replacing their missing teeth. They want occlusion. They want to chew their food. They want to look good. They want to do beautiful smile. That is their aim. That is their. So we have to think about, we have to replace that whole dental organ, not just for the occlusion purpose. So for that, we should always keep it in mind. We should always, when you want to planning the treatment, when you want to execute the treatment, we should always keep it in mind about the biology, the function, and as well as aesthetic. If these three components are intact and is that it relating each other, then the outcome is good. To get this, to execute this treatment, you should always set your goal. How to set your goal? You should set your goal and walk your way back. First, you should think about how it will come out. What is the executing plan? Then you have to work out back. Then you'll get the good result. This is what we always plan. That is all we go over for the digital planning. This is how we'll plan it. This is how we'll execute it. So when you consider all these factors, then it will be good. Then it will be a good success, and you can say it's a success of implant. If you see this case, so always says, if you see the X-ray radiograph, you say that this case is quite good implant, because you can say it's a successful implant. Why? Because there is no marginal bone loss except 1 or 2 mm, and the well also integrated. It's beautiful actually. So if you see this X-ray, you can say, yes, it's a success. This implant is successful. It's fine. It's working quite good. But if you see the clinical pictures of the same patient, functionally it's success, but not aesthetically. Because there's a lack of the keratinous tissue. When the patient smiles, you can see some black threads are exposed, some black smile, some metal is exposed. So we are failed in the aesthetic region, but not in the functional region. So when you want to say the success, you should always integrate structurally and functionally and aesthetically. That's what we consider as a success. Coming to this case, this is one of my cases. It's 8-year follow-up. If you see this case, yes, there is no margin bone loss at all. And even though it's after 8 years and still it's integrated and there is no issues at all. And if you see the clinical pictures of the same patient, yes, it's quite acceptable. The marginal bone, once I can see that the gingival margins are quite healthy and no chance of inflammation, and quite looks nice because we are taking care of all the 3 factors into that. Thus, if you respect the soft tissues, soft tissue will respect you. And so it protects the underlying structures, and it will helpful for the easy maintenance, and it's called as a success. So this is why it's so much of integrate and so much of there is no issues of soft tissues as both is because we always follows there is a zero bone loss concept that's introduced by Dr. Thomas Lincoln. So yeah, there are so many factors involved in to prevent the bone loss. That's called a zero bone loss concept. That is the augmentation of the gingiva, augmentation of the bone, and where you want to place an implant, what kind of metal used for the process. So many things are involved in that. But the major issues is the soft tissue. If you have the good amount of keratinous tissue, if you have good volume of the soft tissues, definitely you can play with that and you'll get the good result. So if you want to say the aesthetically as well as functionally and as well as easy to maintain, so you should always respect the peri-implant zone. What exactly is a peri-implant zone? This peri-implant zone, it play a long-term success of implant, that is the supracrustal complex. This peri-implant zone involves 2 things, that is the crustal bone as well as healthy soft tissues. The minimum of 2 mm soft tissue should be there. It's in the form of the value. Then we can say yes. So if you respect, that's if you don't maintain the supracrustal complex properly, like in between the tooth, implanted to tooth is minimum 1.5 to 2 mm. Okay, and from the margin gingiva to the crust of the bone, it's minimum of 2 to 2.5 mm of the tissues. If you keep this tissue in your mind, and if you manage this, able to manage it, definitely it's good to think over it. Sorry for that. Yeah, and if you keep a safe following distance from the implant, from the adjacent tooth, and you were able to get the nice interdental papilla, and there is a good circulation, it's a good blood circulation to the papillas, you intact, everything is fine. If you don't maintain this, if you don't consider this supracrustal complex, you'll end up with damage of the underlying tissues. So you should always give importance to the supracrustal complex. Why I'm doing this is, there is an article published in 2012. It's eye-opening article. Around 46 to 74% of implants already inserted in the patient mouth is completely absence or partial absence of adequate gingiva or keratinized tissue. So nowadays, so many courses happening in the market. Everyone is giving the lecture. Everyone is placing an implant, and the least given importance to the soft tissues. That's one thing I would like to say. And these initial stages should not come to know what exactly we're going wrong. At the end of the stage, when you go coming to the prosthesis phase, then you'll come to know what was wrong. So there we'll try to correct it, but it's very difficult to correct it. So this is the one thing where we have to consider the amount of the importance of keratinized tissue. This is what the study shows, that this is eye-opening for us to think about when you're placing the implant, about respect the keratinized tissue as well as the volume of the tissues. Is a small tissue. It's around 2 to 3 mm, not more than that. Is a small tissue is a big tissue? Yes, because the plenty of articles is published, including the systematic reviews, case series. All the articles says that there is a significance of keratinized mucosa to maintain the implant health. So plenty of articles in the market, means in the published regarding the issue of soft tissues and importance of keratinized tissues in the implant dentistry for maintaining the health of the peri-implant area as well as for aesthetic is the most important. You should always consider the soft, even they say even though the soft tissue is a small, but it's a big issue created in the later stages. This we already know, there is anatomy is different, the anatomy of the peri-implant mucosa. Why the peri-implant soft tissue is more prone to inflammation is because of the connective tissue fibers, how they arranged in the normal teeth. In the normal tooth structure, there will be perpendicular to the tooth, and so that it will be more relation for the the penetration of the inflammation. Here, the most of the pedal fibers, means the gingival fibers, are more run into the parallel. And vascular supply is definitely a compromise, because here there is no periodont with the what is called as the periodontal components. So there's the blood circulation diminished in this area, and not much of immune cells is present in that area, because the functions of periodontal cells. So those cells are absent in this. Because of that, they are more prone to inflammation. And as well as the junction epithelium. The differences between the junction epithelium, the natural tooth, and the implant is, the natural tooth, the junction epithelium is when the tooth starts erupting, it forms. It's a self-formed. But in implant dentistry, whatever the junction epithelium is, we induce this kind of the repair. We have to create it, then it is in the form of the healing, it's kind of the repair. So that's why it's more weak, it's more permeable for the inflammatory cell to inflate. So that's the reason we always give more importance and should take care of the maintenance of the soft tissues, that is especially in case of implant dentistry. What will happen if thin type biotype of implant, the tissue is present? Nothing will happen, but only thing is, if there is a thin peri-implant soft tissue is there, it affect on the crestal bone loss, that is around 1 to 1.5 mm at the initial stages. If you have the thick biotype of peri-implant tissues, the soft tissue, definitely the crestal bone loss is taken care of that. There will be less crestal bone, and that is the thing what you have to be always considering that. So next question comes, how do I identify? So you can identify clinically. It's the most important. It's not a very big job to find out whether it's a thick biotype or thin biotype. If you just see in the oral cavity, it's very easy to find out. How? Like if you see like this, if there is a thin biotype with this thin diabetes, you can see the translucency. It is more, you can see there is a changes in the color, you'll be able to maintain that area. And if you can use the probe, once you insert the probe into the sulcus, so if you are able to see the shadow of the probe, definitely it is a thin biotype. Or you can use any reamer just to assess the depth, or just you can do the transgingival probing or kind. You can assess whether it is what is the depth, what is the volume, and what is the thickness of the gingiva is there. This is how it's very easy to identify whether it's a thick biotype or thin biotype. When you come to know it's a thin biotype, try to augment the tissues. What are all the techniques, what are the methods to augment the tissues? I'm going to discuss in detail, including with the examples of the nice cases. Is implant placement is contraindicated in the thin gingival biotype? No, absolutely no. Only thing is you have to know when to augment the tissues, how to augment the tissues, which technique is better for it, which material is better for this to augment the tissues, depending upon the area, depending on the requirement of the tissues. That's most important. If you are able to judge, if you are able to get it done, that's fine. That's fantastic. You are going to replace the soft tissues. It's well and good, and it's very easy, and it is, the outcome of the soft tissue augment is quite good if you do it in proper way. It's a very technical sensitive, but if you do it in proper way, the outcome is fantastic, and the long-term maintenance is also good in implant maintenance. When to augment the tissue? This is the most important and most tricky questions, when to augment the tissues. See, there are so many steps in implant. Before implant placement is always recommended. It is important. It means you can plan it properly for the outcome. So if you went along with the implant placement, yes, you can recommend it, but highly recommended when you do the immediate extraction and placement of implant. At the same time, if you do the connective tissue graft, it's good, but less recommended for the other points. So within the implant healing phase, during the second stage, it's highly recommended. Yes, when you're placing the implant, if you're going for the healing abutment placement, definitely that time it is highly recommended, no problem. At least the soft tissue, well, if you're healing the margins, that time only it will soft tissue healing rate. You can easily counter the tissues, then it's easy to do that. It's highly recommended, and before placement implant and with implant healing phase, that's highly recommended. With abutment connections, definitely you can do it. But after the delivery of the implant reconstruction, that is after placing the crown, if you can deliver the processes, then you'll try to attempt. Outcome is little not so acceptable, but it's less recommended. This is how you have to think when to augment the soft tissues. First and foremost, you have to identify whether a thin biotype or thick type. If it's a thin biotype for soft tissues, think for the augmentation. When to augment, you have to choose. What are the risk factor? What are the risk scale of the soft tissues? Well, you want to manage it. So the minimum risk you can expect in the soft tissue augmentation, that is the before implant placement as well as implant healing phase. The moderate risk you can say when there is implant placement, that's all implant and an abutment connection. So high risk during the crown, after the crown deliveries. This is what the risk scale of soft tissue management, which is published in period 2000 in 2020. So the question comes is, which is the best graft? Shall I use the subepithelial connective tissue graft? Shall I use the free gingival graft? Or there are certain materials available in the market to reduce the patient morbidity? Which is the best graft? This is the most common question asked. The autogenous graft is the best compared to the collagen matrices available in the market. But to reduce the patient morbidity, and sometimes we are unable to take this the length of the graft is very difficult to take it. That time we can choose, or we can use the synthetic what is available in the market, and we can use the autogenous and xenograft. That's called a xenograft. We can autogenous graft and xenograft, both we can mix it and you can use it depending upon the requirement of the quantity and of the soft tissues. So why to augment? That's most important. Why to augment the tissues? Basically, to augment the tissues to increases the quality of the tissues, and when good quality of the tissues, if you give the good volume of the tissues, and you augment the good amount of the soft tissues, it heals and it forms the good seal. So with this good seal is most important. That's the reason we're always going for the platform switching, so that you'll get the good amount of good volume of the soft tissues can form nice seal around the implant, so that it will be better for to prevent the more of the inflammation as well as the good for the maintenance. So that is most important. So if you see, there is a zones of healing also. There is a zones in when you go for the soft tissues. Once you take out the cows, if you take out the healing cap, you can see that there is zones, the connectivity zone, junctional zone, and the circular zones. If you have good amount of zones, then your healing is, and the seal is good, then it's a less chance of inflammation and good amount of, you can prevent the the marginal bone. So inside the tissues are very safe if the seal is good. If the seal is not good, that underlying tissues are not safe. So if you do these are my cases, what all the cases I'm showing. So if you do the good tissue augmentation during implant placement, actually this case is come up with there was no label plate at all. But during the implant placement, we augmented the soft tissues, and you can see the beautiful healing, the emerging for how beautiful it is. And if you give it's given the zirconia crowns, you cannot make out basically the patient mount, which was the implant. There's such a beautiful emerging profile you can give, a nice aesthetic profile you can give. And if you're able to handle the soft tissues during the implant placement or during the second stage, during the healing stage of the implant. This is what the patient is so happy if you give this kind of the work. The ears, all the three factors are considered there. So functionally, biologically, and as aesthetic is considered. So definitely because of the soft tissues, it enhances the aesthetic. There is no doubt in that, because whatever the quality of the crown you give, if you don't have the pink tissue, then the white tissue will lose that value. So if you give respect to the pink tissue as well as the white, then its combination is good, then definitely outcome is good, and the aesthetically most acceptable, and patient will be more happy. This is most important. When you form the seal, if you have the good kind of the keratinized tissues, it prevents the periimplantitis. There do not much of perimucositis or periimplantitis is good. So that's the key factor, or key factor to maintain the periimplant tissue is the periimplant soft tissue. So you should always respect the soft tissue when you want to place an implant, and it will help you for the maintenance. So now we'll come to the cases with the gingival augmentations and soft tissue augmentation or implant. Just I'll give you the preamble of my case. This is I placed it in 2020. It's in before the corona. The patient is reported to me for the replacing the tooth. Why I'm telling this is the patient wants replacing the teeth, not for implants. She walked in for not for the implant. She wanted to have a good, beautiful teeth set so that she can, maintain health better with other things. So because of the bone loss, and so you can see the pattern of the bone loss, and there is lack of bone in the posterior areas. So we planned for the we always plan to go into the back way. So outcome is we planned it in advance. So we prepared the 3 models with bone reduction guide as well as the implant placement guide. So we placed it everything, and we chopped up all the teeth. Means we removed all the teeth along with the crustal preparation. So we have gone ahead with the placement of implants. That's all on 4 implants. And you can see that's amount of the soft tissue during the healing phase. So beautiful. The tissue is fine. The way I respected the keratinized tissues, and the volume of the tissue is good. Everything was fine. Then we started loading. It's gone for the second stage. Still, we can see the amount of the soft tissue is quite okay. There is no problem at all. And we deliver the hybrid denture. The patient is walked away, means she walked out of the clinic with happy, and she's fine. And she traveled to USA after 3 years. Recently, I had visited to my clinic for the checkup. You can see the amount of the soft tissues, deficiency now. So during the placement of implant, during the second stage, everything was fine. But now we can see there is a lack of the tissues. There is lack of the keratinized tissue in the lower anterior areas. Then I will remove the processes. You can see the amount of the tissues. Just the marginal bone. This is still here. There is the mucogingival junction. Almost when the patient is moving his lip, the tissue you can see there is a movement of the tissues. This is occlusal view, and see this is almost the mucogingival junction. The keratinized tissue and attached gingiva is only this much. Now we decided to augment the tissue just to increase the keratinized tissue, increase the vestibular depth. So I had given the incision, this is vertical incision, and reflect the partial thickness of the flap. See, we can see there is 2 dark shadows in this. It means the periosteum, it means there is a dehiscence of the implant. So now it's not a good time to go for the augmentation of the hard tissue. Also, my criteria was just to increase the keratinized tissues and increases the vestibular depth. so that later stage I can think about the augmentation of the heart tissue. So main thing is just to prevent the health of the marginal tissue. That's most important for me now in the initial stages. So I just deepen the vestibule by giving the partial, they are reflected the partial thickness of flap. Then I just sutured the whatever the buccal tissues to the underlying tissues. Then here, almost I need to take the free gingival graft around 44 to 45 millimeter. And the patient is almost, she's around 60 to 65-year-old, and she's not willing to go for that kind of the surgeries. She can't take the pain and post-operative things. So she told, you do something, but don't take my tissues from my palate. And as well as I could not get, means even the palate also is a shallow palate, so that I can't take such a big band of keratinous tissue from the palate. So then I just chosen the Nova Matrix. This is a material is available. This is the company, is the Biohorizon company. Actually, this Nova Matrix, they sponsored around worth of 6 lakhs material to conduct the new research in India. So I was lucky to get that sponsorship, and I did a good amount of studies. Now you compared the autograft as well as a xenograft in implant soft tissue augmentation. So I was one of the got an opportunity to do this study. And this Nova Matrix it's a porcine derivative, and it is made up of the collagen type 1 and type 3 collagen structures, and it will replace the new tissues which is from the host itself. So this is helpful for the rapid revascularization, and it helpful for it gives this space for the fibroblast populations and as well as minimal inflammatory response. So this was this material I've chosen to replace or go ahead with the augment the tissues around the implant. And you saw this is the beauty of this material is it can easily modify and accommodate to the counter. It won't tear and all these things, and easy to suture, and is more flexible. And if you want to put the whatever the amount of the force you're applying for the suturing also is quite nice. It won't tear. That is the beauty of this material. Usually, initially they used to sub alloderm. It's a product of alloderm only almost. Then we divided and fused. Yet the thing you should maintain is I just didn't place the tissues around the implants. Just what I created the pouch between the abutment, between the healing abutment, means between the multi-unit abutment also created a pouch. Okay, and I just inserted a tug back, what we call as tug. I just tucked it all the part of the even the whatever the xenograft below the interdental papillas. So I wanted to increase the thickness. So I can increase the volume of the interdental papilla also, as well as to get the good amount of the keratinous tissues, and I can increase the vestibular depth. The year I didn't place any the tags, the tissue tags, or all these things, because it's more expensive for the patient. It's expensive. It's cost around 40 to 45,000 just for the material cost. And we just anchored and you just suture the material with the good number of the horizontal mattress sutures and stabilize with the vertical mattress suture. And the one thing is you should be more careful about this is when you move the lip, the lower lip, the tissue should not move, so that it should be properly adapted. They should not create any dead space between the periosteum, and here we reflected the partial thickness of flap, so it should be intact on the periosteum properly and given the suture. So this immediately will replace the whatever the dentures he had. Then after, yeah, this is small video. Just check how do you going to replace them. This is how we have to check it. So it should not interfere the whatever the tissues we have placed, whatever the xenograft I placed it, and should be always away from that, so that healing will be faster, good. When there is a movement, even the micro movement of the graft, it won't heal. It will reject the graft. Sorry for that. This is a 3-month post-operative. I could get the good amount of the soft tissues in inter-implant, that's kind of inter-implant areas, and as well as in the label portion of the implant, and increases the good amount of the vestibular depth also. If you see, this was the initial when I was before operating, and this is what increases the depth, so that now the mucosal junction is shifted little apically, and the patient can maintain this area properly. And I'm so happy that we got a good amount of this. It's not so great because we increase the depth around 10 to 15 mm, almost 10 to 12 mm, but around 6 to 7 mm, I can get that. It's more than enough to maintain that. So there's a pre-operative and there's a post-operative. You can see the differences. You can see there is the frenal pull. There will be, there is a thin bite of the gingiva, and the mucous junction almost it's 1 to 2 mm from the margin gingiva. Now I could increase this 5 to 6 mm minimum, and that's it. This is the beauty of that material. Not much of a complication come across this case. The question comes is, if you do augmentation before the implant placement, it's always recommended, and you can, beauty of the tissues you can manipulate during implant, during implant placement, or during the second stage also you can manipulate it however the shape you want it. That's always better. This is a case, we augmented the gingiva before placing the implant. If you see because they lost, the patient is a female patient, she lost her teeth because of some trauma, and there is the deficiency of the soft tissues both vertically as well as horizontal. Hardly you can see the marginal, so there is a mucous junction. You can see the movement of the tissues is around 2 to 3 mm, not more than that. So this is the horizontal defect. Also, you can see there is a huge defect in the level surface. Now the effect, we have to think about how to increase the vestibular depth, increase keratinoid tissue. There are two options when I can do the apically position flap, or I can go for the vestibuloplasty with the FZZ. I always choose, I'll go for the vestibuloplasty with the FZZ. We can, the prediction, the outcome prediction is too good in this. So given the vestibuloplasty, extended from the canine to canine, almost canine to canine means lateral incision, the canine to lateral incision, and the partial thickness of flap is deflected. I'll give the incision and deepen. How much I can do? I'll just go for with the deepening the vestibule. When I taken the free gingival graft from the palate and with the horizontal mattress suture and just stabilization suture, angle sutures, I sutured it properly, and there is no movement of the soft tissues, whatever the augmented tissues. Then this after the 2 weeks of healing. This is after 3 months of post-operative. The only drawback of the free gingival graft is the color match. You'll get the good result. You'll get the good amount of the keratinoid tissues. You'll increase the width of attach. You'll get the volume. You'll get the width. But the only drawback is the color matching. If it is not in aesthetic zone, this is the best technique to. This is the best method to work with that. So this is 3 months post-operative. You can see the good amount of soft tissues, and I shifted these tissues. It's a mucous injection, so that we increase. Here, only thing is I could not attempt here. My intention was to increases the keratinoid tissue, increases the width rather than the volume here in this. This you can manipulate during the implant placement also. This was the pre-operative, and this is the post-operative. So how it was the initial and how it becomes. In fact, they placed the one single implant with the cantilever, the bridge. This is off after the implant placement. This is how we got it. Patient is also happy, and patient can able to maintain this area. Patient can brush this area. That's less chance of peri-implant mucositis or peri-implantitis. During the second stage, also recommended, but it's a less recommended, but you can go ahead with that. So this is a patient referred to me. After placement of the abutment, you can see they not clean the abutment at all because patient is unable to maintain that area because of lack of keratinoid tissues. There is no vestibular depth, and there is, you can see the frenal pull. That means there is a soft tissue pull around them. Almost this pull is attached to the marginal gingiva. And whenever patients start brushing, you'll get the ulcer like this because of the trauma. There is no vestibular depth. That's the issues with that. Then you can see the now option is I need to increase the vestibular depth, and I need to increase the keratinoid tissue also. I chosen for the free gingival graft here because it's not aesthetic zone. The patient lip line is somewhere. That's easy to do it. And same, I just separated the tissues. I got the partial thickness flap. The periosteum is intact. Okay. Then I've taken the free gingival graft from the palate and just stabilized with the anchoring sutures. And sorry, This what to stabilize it, and whatever the lip is, I never leave the whatever the soft tissues around this towards the lip. We always suture it to the underlying tissues. Then it's easy for us to maintain that area so that it prevents the reattachment also. Then I place the pack. This is of the post-operative, 2 weeks of post-operative. So here whatever the pull of the tissues was there, it was relieved it, and I could get the good amount of tissues both in volume as well as like in the length also. So increases the depth also. I could get good amount of the tissues around the implants. Now patient can maintain it easily and he can brush it properly, then less chance of periimplantitis. You can see the difference between the preoperative and post-operative. Good amount of, I feel I got a good amount of soft tissues around the implant, even though it is post, but still I could get it and the patient will be very happy. Then you can refer for the second stage. You can go ahead. This was the pre-operative, and what amount of got it is the post-operative. This is the most of the tissues. We always think that we can take it from the palate. There are certain areas, if they depend upon the quantity of the tissue you may require. If it's very limited amount of the soft tissues required on the single tooth, that time you can single implant, then you can think of taking the tissues away from the palate also. So this is a case where I taken the soft tissue graft next to the implant placement, next to the implant. You can see there's a preoperative. There is the polished collar is there, fine, no problem at all in the tissural implant, but still there is amount of the less amount of implant is exposed, and the patient was more concerned about the black color. So she had referred to us for the soft tissue augmentation, fine. Then there was marginal bone loss was there already. Then what we can do it is, I taken, see what exactly is distal to the second implant, there is a third molar and there is a deep pocket was there. And here there's a good amount of soft tissue you can see. So what we did is just you had given the vertical incision like LANAP, what you can, so it's yeah, what you can call is the kind of you can give the vertical incision, okay? So just till the base of the pocket, okay? And you hit the bone and take out the chunk of the soft tissues. So you can. So here I'm getting both the gingival as well as means the free gingival graft. It's the epithelialized and as well as the connective tissue. I'm getting the chunk. It's easy to manage it. And there was a pocket in this area. So because of doing this kind of the gingivectomy, I can eliminate the pocket also. So it's a 2-in-1. And remove the chunk of the tissues, and whatever the innermost part that is towards the tooth second was a pocket. So just we scraped it, removed all the layer of the whatever the infected pocket, what gets at the epithelium. Then it's a combination of the it's a combined graft. It's a combination graft. It is like the epithelium was intact as well as the connective tissue. Then we reflected the parcel this full thickness. You can see there are 2 to 3 threads you can move exposed. Then you place the whichever the epithelium portion at the epithelium, that's the margin tissues, and you push the connective tissue, then sutured it. You can see when graft is placing and anchoring, suturing it, then you can see the preoperative and post-operative. Yes, I got a good amount of the tissues or an implant, and the most important thing is I eliminated the pocket also in this area. So there is no source of infection also next to implant. So we're done. So this is how you can think when you the differences between the graft taking from the over the ridge and as well as from the palate is the over the ridge. If you take the palate, is extraction socket, all these things, the connective tissue will be more and less vascularity. That is the only thing you have to keep it in mind. And sometimes when you don't have options like this, and we always before taking the graft from the palate, I always prefer to prepare a hard splint. Okay, so that easy to control the bleeding and less post-operative complications also. And patient will be more comfortable because I always advise the patient put the hard splint immediately after taking the graft. So for 7 to 10 days, patient will not move that. So that the healing will happen nicely and not much of discomfort. Patient will enjoy the food also. There will be no problem and no bleeding issues post-operatively. If you put a suture and put a pack, anytime pack may come out, then again patient will have a lot of discomfort while eating. So this is another case. I taken the graft from the tuberosity areas. Most of the times, if I The small areas, only the graft is required in the single implant areas, and not prepared the hard splint. And just you can take the thing or it. Another site is the tuberosity area. You can just take the tops of the graft from the tuberosity areas, and you can just suture it in that. And patient discomfort is very less if you're taking it like the extractile socket site area and as well as the tuberosity areas. This is how we can manage, even if when you require a soft, means a very less amount of tissue is required. This is a nice place to take a graft from the source of autograft. Sorry. This is what I always practice, taking the connective tissue, especially in case of when you're placing the implant in the aesthetic zone. The connective tissue is the best. When you're placing the implant, there itself you just suture it and it heals beautiful. The tissue content can get it, and less chance of shrinkage of the soft tissues, and less chance of the marginal issues will be there. So this is what we always practice. In fact, I learned most of the techniques from the UK. So they always practices. This is a major things, especially in the anterior zone. They always augment with the small amount of the connective tissues. So I already discussed about the alternative to autologous soft tissues, that is a xenograft is already in the market, whereas many companies are supplying already. So this is another case that's I used frequently the Novomatrix as well as the Mucoderm. This is also same, the source, what they prepare from how it is, and the same, the how it will undergo the resorption as well as the replacement. This is one of the beautiful case. You can see the vestibule depth is almost zero. There is no vestibule depth, and the volume is also very less for this area. The patient insists, patient wants to go for implant. Definitely before placing implant, you have to think about that. But if you see after the placement implant, still the patient, they refer to me to augment the tissues. Patient is unable to maintain that area, and the margins is almost at the vestibule depth. The gingival margins of the implant is almost at the vestibule depth. How patient can maintain this area? That's very difficult to do that. And we plan for the this is what the vestibule depth almost at the margin. So this is what with probe you can see there is no vestibule depth at all. There is no keratinized tissue at all around the implant. So as usual, so just when I need to do vestibule depth, I need to increase the vestibule incision, then reflect the partial thickness flap. You will always create a pouch between the implant also, so that I can tuck the material. I can tuck the material below the tissues also, so that I can get the good amount of volume here also along with the vertical. So here I just separated this. This is basically the supraperiosteal, so that periosteum is intact. That is important because we should never denude the bone. That's most important. Should never remove the periosteum. That's most important. That's vascular supply. Then I placed the mucoderm. Here I used the mucoderm nicely. Then I stabilized it. And here, because the tissue was so thick, I was able to split it into two. So first I taken it to the connective tissue so that I can, stabilize this, whatever the lip, the tissues, and you can suture it back. Fine. So this is the tissues, and place the periodontal pack. And this is after 5 days. If you see this like patient, if you see this, some it gets scared. Even the dentist also sometimes they may get scared. Something is happening, whatever the tissues get. So the beauty of this material should be more happy that if you see these kind of the bleeding points or kind of the pink tissues healing, it means the volume. Any graft you place, whether it is autogenous graft or xenograft, the superficial layer is going to necrose because there are not much of good amount of bone. The blood supply will not be there. Definitely, this is part will get it's necrose and it will go away. And you should see for the tissues. This you can see for the any kind of the granulation tissues coming up. So it means it's taken up. It's not resected. It will help you for the regeneration or augmentations. Sometimes patients want to go, you have to keep these sutures sometimes more than 10 days also. That time patient is unable to maintain that area and they want to go to office and all these things. That time I can go for the X6 appliance with the teeth so that the wound is also protected and still the tissues also maintain this area. That's fine. After 2 weeks, we can remove that. This is what there's a preoperative, this is what the postoperative. I could get the good width of the tissues also, and well as good amount of the keratinized tissue, and I could increase vestibule depth also. And now patient is happy, he can go for the next stage. This was preoperative. And I can see where is the depth and how much width I got it. So I already explained about the alternative that one more things. So this is after the implant placement going for the second stage. That time there is a deficiency of the soft tissues. You can think about this is where you can manage the connective tissue. The ideal graft to place in this kind of the cases is the connective tissue graft because it's an aesthetic zone, and here already there is a good amount of vestibular is there. Just I need to increases the volume of the tissues. When you plan for the volume of the tissues, when it's an aesthetic zone, the best graft is go for the connective tissue graft. The patient is not willing for the second set of surgeries, then ultimately I have to choose the alternative graft, that is xenograft. You can see there is just 6 to 7 mm of width in this area. The partial thickness of flap is raised, and here I did preserve the papilla. That's one thing is I just dissected the papilla also because I wanted to increase the good amount of the volume of this interdental papilla also. So we dissected the interdental papilla also, reflect the partial thickness of flap. You can see the implant here. Then see there are a lot of the sizes of the matrix is available. So 10 to 10, 10 by 10 is 10 millimeter to 10 by 10 millimeter 20, 10 millimeter 40, all these things. So we can go for the smallest one. Then we just stabilize the membrane at the vestibular depth, that's ankle suture, just pull it inside and stabilize it, the apicalmost portion of the vestibule. Then we can easy to reshape it, whatever the shape of the is required is beautiful. You can reshape. You can see that's exactly how much I wanted in that area. I can reshape it and pushed it and sutured it. This is the closure suturing date. You can see there's good amount of tissue. I got it in interdental areas as well as in the apical areas. The later, you can see there's the post-operative what amount of tissue I got it, and there's a deficiency pre-operative. In fact, they are gone for the second stage. So you can see here they could not close the space because in other area also there is interdental space. Patient wanted to go for this kind, and here they had good amount of soft tissue. I got it in the volume also. Because here I cannot go for the interdental papilla. This is you have to think about in a different way because the margins. This is a pre-operative one as well as the post-operative. Yeah, this is one of the beautiful case again with the Nova matrix. And you can see this a pre-operative before. There are multiple areas they attempted already for the soft tissue augmentations. They already, patient is undergone for multiple times in multiple places for this to increases the keratinous tissues and as well as increase the volume of the tissues in this area, but they could not do it. So initially patient is, because it is a referred to me from another dentist to say already they undergone for the free ginger graft from the palate, but they could not get the good amount of the outcome in this area. And the patient is referred to me, then patient is not willing for this because already she undergone for the autograft. They're taken it from the palate and they run all these things. They could not get the good result. And second option is left with me is I can think about the xenograft, that is alternative for that. After removal of the prosthesis, you can see the amount of, you can see there is not much of vestibular depth but also, and there is a scar formation. You can see there is a lot of scar formations. It's already happened in this area. So this is what the amount of attached tissues I can see in our mouth. Then this is what is that. You can see there is amount of the scar tissues over the stairs because this is already undergone for one round. So again, I can increase this and given the supraparietal incision and reflected the partial thickness flap. I separated the lip, the mucosa, and I just see after placement of this, how much, this is just during the surgeries. And here you can see there's a lot of tissues. So I need to remove all the tissue tags properly because a lot of the scar tissue was there. I made it uniform and the label surface of the jaw, that is the gingiva, and taken the 40 to 20 mm of the soft tissue means like a substitute that is from the no matrix. Then just I sutured it. So here also I created a pouch. I just able to push the material because I cannot leave the edges, the free edges for the gingiva as well as the graft. So I need some blood supply to the margins of the graft also. So I need to push it below above the periosteum, below the gingiva and below the mucosa basically, and establish in the lingual areas. And given the two vertical means the I need to stabilize it with by means of horizontal as well as vertical matrix suture. I'll try to avoid the tissue tags because this also leads to some more burden to the patient. This is what after 5 days post-operative. So suddenly patient is walked and came, as something has happened, is full of whitish. I think the graft is resected again. So some issues won't happen. This is a normal healing during this period. Nothing to worry. You can see there is kind of the tissues. You can see there is a where there is the healing granulation tissues and changes in the color. That is what our think, okay, this is taken up, nothing to worry, just whatever the superficial area is going to necrose, that is because of lack of the blood supply to the area, is what would happen. If you see after the removal of the sutures, you can get a good amount of the soft tissues, the value and as well as the length of the soft tissues I could get. It's 2 weeks post-operative. If you see this at the it's end of the 2 months, you can see good amount of there's removed all the scars. Initially there was a pull till ear, but you can see there is how much the depth of the vestibular got it and increase the keratinized tissues. Now the patient can able to maintain it. Now patient is very happy, and we are also. Only thing is I could not get some amount of tissues in this area. This we can think about just for the lateral positioning. There's kind of the pedicle flap. No need to take graft from anywhere. You can just push the amount of whatever there is a thick tissues. I planned it to take out the little bit of pedicle graft and push it. Then it will be that the patients also taken care of that. This is what we'll get it in the post month. This was what the initial. The depth, what I got it in the post-op after the 4th month, this is quite good amount of tissues. I can see the P initial. You can see the amount of means the preoperative, the scar tissues, the attachments, the frenal pull, how it was, and how beautiful I got the tissues around implant. Now this is what. In fact, I went with, I had to the biopsy also because the company claimed that it is completely replaced with the natural tissue, means the autologous graft, it will convert into the natural these things. I went with the biopsies also and got the biopsy report and everything. The oropathologist said this, sir, everything is a natural and nothing is, there is no remnants of the soft tissues in this. I always respect Dr. Patrick Palissy because he is more towards the soft tissue management, he is more towards the soft tissue augmentation. He insists for the soft tissues. He always worked with the Brandmark as he was with the company in the team of the Brandmark. But he is I always respect him and I always follow his techniques. The Patrick Palissy techniques is the most widely used for the reconstruction of the internal papillas. That's a beautiful technique. I always follow this. The only thing is the Patrick Palissy is when you have the multiple implants each next to each other. That's most important. I can do only when the implants are in a sequence. The implants are placed next to each other. Then only I can do this. I can try for this technique, and especially you can in case of aesthetic zone, especially in case of the maxillary, where you have the thick bite of tissues. When you're going for the second stage, when you want to remove the cover screws, when you want to go for the healing cap. That time will give the horizontal incision at the palatal most areas and reflect the full thick, means reflect the tissues completely. Then we can see this what we'll do it. We'll give the 2 vertical incision and give the 1 horizontal incision at the palatal areas and reflected the full thickness. Then we'll give the cuts in between the implants and it's kind of the pedicle graft. We'll move those whatever the cuts of the tissues into the inter-implant areas are sutured it, and you leave it for 10 to 15 days. Once you take out the implant, you can take out the healing cap, you get a beautiful implant. This is my case. So that's the same technique. I done it. This is after 2 weeks of, means it's 2 months almost. You can see the beautiful, the internal papilla you could create, because the only thing is this technique you can do when there is the implants next to each other, and when there is the flat tissues converting into the internal, the papilla, the beautiful outcome, the beautiful aesthetics, you can get it without taking the graft from anywhere else. The only thing is you should have good amount of, thick bite of the gingiva. We can expect in maxillaries. This is what is my case. How I could get the beautiful, the patient was happy and nice processes you can give this areas. Can I use PRF to get in keratinized tissues? Yes, we can try, because Sometimes I use it, this technique, especially in case of the mandibular areas, just to increases the quality, means increases the thickness of the soft tissues, and as well as increases this. This one case I tried it out. So it was very thin. I just given the vertical instance. I always preserve the papilla when you wanted to go for the second stage, try to preserve. So you can give the crustal incision and reflected the full thickness of flap. So you can see it was very narrow, ridge was there, but we reflected. I wanted to get the good amount of thickness. So the volume, basically. So I use the PRF. Okay, so it'll just follow the kind of the Palissy technique, but I didn't use the one graft. I can just place the PRF between the implants and stabilize that PRF membranes with implants with the horizontal mattress suture. Right. So I didn't approximate this flap into this flap. I just left it open with PRF membranes are exposed, nothing to worry. And after removal of the tissues, you can see good amount of the soft tissues I got. So I increased the width of the tissues. That's basically I could get good amount of the soft tissues or an implant, good amount of the volume of around the implant. So this how much tissue I got it. It was completely lapsed. Now I can get the good amount of the width. Now I can go with the processes. Go for the next positive phase. If this work, we did. So even PRF also sometimes I use it if it's minimal. The only thing is around 2 to 3 mm we can get. This is healed with the second intention. Basically, it's healed with the secondary intention. Yes, well, always we can't say that this. I can't say everything is whatever the treatment we do it, everything is a successful, nothing like that. There is a chances failures. Only thing is we should assess why there is a failures. In the next step, we have to avoid those kind of, we have taken care of those steps so that we can prevent the failures, we can minimize the failure rate. So one patient, actually this is a case for the gigantic implants or pterygoid implants. Patient is not willing to do any kind of this. And we had to go for the vertical augmentation of the graft, means hard tissues. Patient was not willing for the sinus lift. So one of my postgraduate will let us go for the block graft just to increase the vertical height of the hard tissues, especially not going, instead of going for the sinus lift, we'll just go to the block graft. Let's see how it works out. But it didn't work out. We placed the hard tissue graft. You can see we just stabilized the block graft, and we could not close the flap. We given the maximum releasing the periostalizing incision to verticals, but still we tried to approximate. You can see there is amount of the tissue could not close it, especially it's end up with the necrotic bone. So the now next thing is, so we thought we'll try to close the soft tissues by using the free gingival graft. So here I modified the free gingival graft into the, so like a butterfly graft. So what I could do is in the center part of the tissues, means epithelium is intact. I just remove I'm sorry, some disturbance. So I could I'll remove the de-epithelize in the mesial side as well as the distal part of the tissues, and it's kind of the butterfly. The connective tissue part is gone below the buccal flap as well as the palatal flap, and I could expose the keratinized tissues, means that is the epithelium, so that I was thinking I can get good amount of the tissues and there is good amount of soft tissue coverage. But here also I failed to get it. This is basically because of the vestibular issues, and ultimately we tried. The graft is neglected. This is because of the lack of the blood supply. Any graft to success is the vascularity and oxygen supply to the tissues. That's most important. When you are not able to do it, because there's the block graft below that, I could not get the good amount of the vascularity and as well as oxygen supply to the tissue cells. So definitely is going to fail. This as well as there's a micro movement of the graft also was there, that could fail this. But only thing is we used, there is a new material is available in the market. There's a collagen plug just to close that area and disclose it, but still it's not. Now question comes is, seeing all these things, which is the best grafter to use it? So you can think always the autograft is a good grafter to use it. Only thing is some case when the patient, if you think about the patient morbidity, you can think about the amount of the tissues required. that time you can think about the xenograft. Otherwise, autogenous graft is a fantastic graft. Some complications during the surgeries. This is what when you don't use the proper the palatal closure, this is what patient will end up with, getting the hematoma kind, and patient is slough around the wherever there's a graft tissue is taken from, wherever the graft is obtained, so the donor site. So patient is reported after 5 to 6 days. This is not my case, but somebody is referred. So you can see there is a lot of hematomas in that area, and the patient is unable to do anything. Patient is unable to brush, unable to eat, and all these things. This is the proper complications, because we are not, they could have managed it in well after taking off the graft, they would have closed it properly, but they didn't it. This is what end up with this. Then ultimately I need to remove all the clot areas and slough areas and treat it properly. This is what after cleaning up the tissues. This is what after removing off the what was the areas. Then I could heal it properly after 2 weeks. After 3 weeks of the patient is reported with happily, there is no issues at that. So we should always think about the donor site also, not only the recipient areas. We should take care of in both sides. These are all things we can avoid by taking the little bit of precautions. You can avoid taking care of this. This is a preoperative, and this is a postoperative. And sometimes, if this is another case. So they are transferred. These are not my case. These are how you can manage the complications. That's what I'm showing it. This is what about the donor side. These are recipients adjacent to each other, but both the graft also resected, and here the complication happened in the recipient area also. This is because of the suturing issues and as well as the graft. This is what taking the graft is not an issue. How we go to stabilize that graft is the most important. That is a critical stage. That is important to outcome of the result. Okay, so those things you should try to taken care, and those things you try to manipulate. Those things you should be more careful about the soft tissue augmentations. It's not an easy job. But once you keep trying it, definitely it will become more easy job, and it's a day-to-day practice nowadays for the soft tissue augmentations. It's a fantastic job, and it will get the good result if you do it. Only thing is, during the treatment, you should be more careful of the bleeding, as well as what kind of the graft you're taking, where you're taking, all these things. You should keep it in mind. And this is about this is also another case referred to me to manage complications. This is all purely graft rejection. Okay, and seal with this slough. Definitely, we removed all the tissues. Now we can't do anything other than palliative treatment. Just clear it everything and ask the patient to apply kind of little bit of the anesthetic gels and maintain the healthy. We always advise for the antiseptics or some things. You can apply that, and patient has to maintain that area till it has to heal. Later, we have to think about what best we can do these kind of the patients. The last but not least, I should end up my practice. I should end up my presentation. So take a message. In case of tooth removal, we have to deliver implant-borne prosthetic reconstruction with harmonious, hard and tough tissue environment. This is the most important. You should always think it in mind. So we always say the tissue is an issue. Yes, but many people say bone sets the tone. When you say the bone set the tone, so 3D alveolar reconstructions with horizontal and vertical augmentation can be performed predictably. That's most important. You can do the hard tissue augmentation is you can predict most important compared to the soft tissue augmentation. So prediction is more in the hard tissue compared to the soft tissues. So tissue is an issue, is a soft tissue. That is the sufficient width and thickness of the keratinized mucosa is necessary to maintain the previously reconstructed hard tissues. Yes, you've done hard tissue. I showed you one case. I did hard tissue augmentation, but I could not maintain the soft tissue convergence. Then it fails both. So we have to learn multiple techniques and multiple the tissues you should know about that. Then the most important is the case selection and graft selection. So when you want to go for the major case, what kind of graft you have to take? If you want to go for the localized areas, what kind of you have to take? Which graft is essential for that? Which graft is a less complication? Which graft is a more important? Which graft is more aesthetic acceptable? All these things you have to keep it in mind. Then you have to forward it to the soft tissue maintenance. The last but not least, thank you so much for joining this webinar, and as well as giving it time to listening to this. I'm so happy for you people, and I could share whatever I know it. I hope good. I hope this will be helpful for you people in the practice. And thank you so much. And once again, I should thankful to the team of the ISPRP team giving an opportunity to present my cases and share my the experience. Thank you so much.
Thank you so much, Dr. Mahendesha. Now we have some time left, around 5 to 8 minutes. We'll take some questions which has been posted in the chat box. I would request our moderator, Dr. Umesh Pai, to start with the discussion. Thank you.
Yes, thank you, Dr. Mantesh, for that very insightful lecture. And yes, hello,
Yes,
am
yes,
I
sir.
audible?
Yes, sir. Yes,
Yes,
sir.
yes. I completely agree with you that, the emphasis on keratinized tissue around the implant is a very, very important aspect. And, I think you have thrown very good light on it in the past 1 hour.
Yes, sir.
We do have some questions, some of them from me itself.
Yes,
Uh,
sir.
so one was how important is developing proximal contacts with the prosthesis to ensure papillary fill?
Yes, it's very, very important, sir. Sir, the soft tissue only periodontists can manage. And if you know the Tornos classification, so if the proximal contact is, especially I showed you on the Palissy technique, the prosthesis makes most important for the getting the beautiful countering of the gingival part, especially in the interdental area, the prosthesis play a major role. And what kind of material you're using, that's also makes a lot of differences. So the role of prosthodontist play a major role in aesthetic, especially in case of interdental papillus, especially in case of interdental papillary reconstruction. And as well as I told about the supraperiosteal complexes, and as well as that the distance between the one tooth to another tooth, if we're able to keep it, if we're able to manage that, so definitely we can get the good amount of aesthetic papilla and as well as good amount of the soft tissues. So here the prosthodontist role also play a major role.
Yes. Yes, sir. Thank you so much. And there is one more question from Dr. Aditi Gupta. Sir, do we have to place periodontal pack after leaving PRF exposed to the oral cavity?
No need, sir. No need. I didn't place it actually. If you want, you can place it just to protect the food lodgement as well as food debris and just to avoid any kind of means you can place it. There's nothing like that. So you can place it.
Okay. Yes, I hope it answers the question. Sir, there was one more case that you showed at the end. That was the block graft case where you did, and
Yes,
there was a failure of the gingival graft as well.
Yes, yes,
Now,
sir.
my question here is, could you have done a VIP CT graft in this case, just to ensure the vascularity?
Yes, sir. Yes, sir. Definitely. In fact, more than that, sir, I would have done that like, the pedicle graft. That's what you mentioned. It's a pedicle graft was ideal, but it's my failure case. Sir. That's after that I learned actually. So
okay.
I was thinking the connective tissue and gingival graft, both I can help it. But the best thing was the pedicle graft was the best thing in this case. That I failed to judge during that time. So now this is what why I'm showing is just to don't make the same mistake what I made.
Yes, we all learn from a failure, sir. We all have done that.
Yes, sir. Yes, sir. So the pedicle graft was the best graft during that time, so that I could maintain the vascularity intact and better for that. So here it was a failure basically. In the planning was not good in that day, but definitely. Yes, sir.
So there's one more question from Dr. Anahita Punj, where she asks, in the case where soft tissue was removed near the molar, any additional instructions to allow for early healing of the wound?
Nothing instructions, sir, especially in the molar areas. If taken from the over the bridge, nothing more instructions. Just normal extraction, post-operative instructions only. Just to use Lucom or to start gargling. That's it. So nothing more. No, nothing special in that area.
Okay. All right. So there's one more question from me. Does
Yes,
mucograft and fibroguide from Geislich, do they have the same role, or if they are different, how different are they from each?
Both are same rule, sir. Both are same rule.
Okay, so there is no difference.
Nothing, sir. It is only company people are there. The difference is in the materials, sir. Actually, the functions are same. The what you want to replace is same. The handling property is totally different, sir. So if you say for the mucoderm, mucograft, whatever this is, that comes in dry. What they come in the dry. Fine.
Okay.
So before using it, you have to soak it in the saline for 10 minutes. Then you have to suture it. That's one thing. But the Nova Matrix is already, it's a pre-wet. It's already preset. Everything is intact. Just you have to put it in the patient mouth and you have to suture it. It's already pre-fabric, means what you call is free or manufacture, whatever you call it as. So no need to take it out and put it aside. One thing. The second thing is the handling property. So my personal experience, the handling property is very good in Nova Matrix compared to Microdot. The reason behind that is it's very stiff, and you can tie it, you can kind of suture it, you can directly suture it. That's a very good property in that. So that is what I felt is, because I use both graft, the property wise is, I felt the Nova Matrix is better than this.
So whether it is mucograft or fibroguide
Yes,
or
sir.
Matrix, we can use it both for connective tissue as well as free Chinjabi graft.
Yes, sir. The most of the times you can use it as a connective tissues, most of the times.
Fantastic. Okay.
Yes, yes.
This is something that I needed to clarify from somebody who was authentic, because company people tell you different things at different times.
Yes, sir. Yes, sir. Yes, sir. The only thing, yes, sir.
Thank you so much, Umesh. Thank you so much for the discussion. So I think we have exceeded the time limit. Mahintesha, thank you so much for this wonderful presentation. Now, as the scientific chairperson, I would like to thank Dr. Mahintesha once more for spending time with us to share his expertise, to share his knowledge with all of us. And not only the cases which have succeeded, but he's also shown few cases where how to set things right. So that speaks volume of how he wants to share all the aspects of soft tissue management in implant industry. Thank you so much, Dr. Mahintesha. It was a beautiful lecture.
Thank you so much.
Thank you so much, Dr. Umesh, for chairing the session and asking the questions on behalf of the participants who have posted the queries on the chat box. Thanks to Dr. Divya. Thank you so much for being a part of this ISPRP webinar series.
Thank you, Dr.
I just
Manuel,
wanted to let you know that every month, 4th Sunday, 10:30, we have this program of online webinar. Please, those who are here, please be a part of it. We will be circulating the brochures in all the groups, and I will be emailing it to you all as well. Thank you so much. And regarding the participation certificate, since it's an online event, many times some of the participants, they have this issue of not getting the certificate. So what we'll do is, those who are the participants, I have their email ID. So I will send the link for the feedback. Once the feedback is filled, you will be getting your participation certificate. In case any issue is there, please do email me back. I will do the needful. And these are our upcoming webinars for the month of October and November. This is the feedback form. Those who want the certificate immediately, you guys can scan this using Google Lens, and you can just fill up the form, and immediately it will be emailed to you, your participation certificate. Those who haven't received it, I will email you the link in a couple of days. And one more thing I wanted to tell you is, after every webinar, we have a post-webinar quiz after 4 to 5 days. The link for that also will be sent to you. So part of a new initiative, this post-webinar, the person who gets the maximum answers right for all the webinars combined together will be awarded at the conference and next year. So please try attempting these post-webinar quizzes. So thank you so much once again. And before I end, we SRM team as well as ISPRP, we are really excited to announce the UG convention for the first time in December 15th and 16th. Kindly be a part of it. If not, at least tell your undergrad students and postgraduates to be a part of it, to experience all the 3 specialities, and to be part of it by presenting papers and posters in the event. Thank you so much once more. Thanks everyone for sparing your time. Have a nice Sunday. Thank you so much.
Thank you. Thank you so much. Thank you.
Thank you, Dr. Mahintesha.
Thank you so much.
Hello.
Thank you so much.